Module 7. Special Populations and Modifiers. This is Module 7 of Delivery Room Labor Failures, Special Populations and Modifiers. By this point in the course, the major rules are no longer isolated facts. Failed induction requires an adequate trial. Active phase arrest requires the 6-centimeter gait, ruptured membranes, and enough time with contraction assessment. Second stage arrest requires mechanics, not only a clock. Oxytocin requires fetal reserve. Operative vaginal delivery requires a deliverable pathway. Now we ask a more sophisticated question. What happens when the patient is not the clean average patient for whom the general rule was easiest to teach? The answer is not that the rules disappear. The answer is that each rule must be interpreted through modifiers. A modifier is a condition that changes the cost of waiting, the safety of augmentation, the probability of vaginal birth, the morbidity of cesarean, the danger of infection, the tolerance for fetal tracing abnormality, or the resources needed for rescue. TOLAC modifies uterine risk. Macrosomia modifies mechanical probability. Diabetes modifies fetal size, shoulder dystocia, and metabolic safety. PROM modifies infection exposure. PET modifies maternal tolerance for time. Hemorrhage risk modifies route planning. Anticoagulation modifies anesthesia and bleeding strategy. Twins modify monitoring, presentation, and team readiness. The art is to preserve the general criteria while refusing to apply them blindly. Start with TOLAC, because it is the clearest example of a true modifier.
TOLAC is not simply multiparous labor. It is labor in a uterus with a scar. That scar does not make vaginal birth impossible. In fact, vaginal birth after cesarean is often the best outcome when it is achieved safely. But the scar changes the meaning of induction, augmentation, fetal heart rate changes, second stage duration, and delay. The Israeli position paper gives VBAC success rates around 60 to 80% among women who choose a trial of labor. Local data are more concrete. In Hadassah, the TOLAC rate was about 75%, with success around 60% in a woman who had not previously given birth, and around 84% in a subsequent delivery after cesarean. This is exactly the type of number that should shape counseling. A patient with a prior vaginal birth is not the same probability problem as a patient whose only prior labor ended in cesarean for failure to progress. Uterine rupture is the central feared event, but it must be taught numerically and mechanistically. The Israeli position paper describes rupture as more common with TOLAC than with repeat cesarean, around 0.4 to 0.9% in spontaneous births, and around 1.1 to 1.4% in induced or augmented births. The local protocol cites 0.7% in the largest prospective comparison. These are low absolute risks, but the consequence can be catastrophic. Maternal hemorrhage, transfusion, hysterectomy, infection, fetal hypoxia, asphyxia, or death. So TOLAC is a classic obstetric trade-off. Successful VBAC avoids repeat operative morbidity and reduces future pregnancy risks, such as placenta previa and accreta. Failed TOLAC, especially with rupture or emergency cesarean, concentrates morbidity. The resident must hold both truths at once. The first practical rule is progress interpretation. The Israeli position paper says labor progress criteria are the same as regular birth. But if the woman has not had a prior regular vaginal birth, the expected progress is similar to a nulliparous woman. This is a quiet but crucial point. A patient with one prior cesarean and no prior vaginal birth is not physiologically proven as a multipara. Do not grant her the progress expectations of a proven multipara simply because this is her second pregnancy. The second rule is augmentation. The Israeli position paper says there is no contraindication to oxytocin augmentation with monitoring of uterine activity and fetal heart rate. The local protocol is more restrictive operationally. Pitocin may be used at a quarter dose up to a maximum of 20 milliunits per minute. Induction requires senior approval. Low-dose Pitocin, balloon, and artificial rupture are listed induction methods. Prostaglandins should be avoided locally because of increased rupture risk. and reassessment is required at 12 and 24 hours after Pitocin begins. Pitocin beyond 24 hours is allowed only if active labor has been reached.
Do not reduce that to oxytocin yes or oxytocin no. The correct teaching is SCAR plus dose plus monitoring plus senior judgment. Oxytocin in TOLAC is not ordinary augmentation with a SCAR mentioned in the background. The SCAR is part of the pharmacology because dose-dependent uterine stimulation changes rupture risk. The third rule is second stage. The local TOLAC protocol limits the second stage in a first TOLAC to 2 hours, extendable by 1 additional hour if an epidural has been administered. That is stricter than the broad ACOG second stage framework, and it reflects local SCAR safety practice. In a first TOLAC, the second stage is not only a descent problem, it is also a SCAR exposure problem. The fourth rule is recognition of rupture. The most common sign is fetal heart rate abnormality. Local sources also emphasize uterine hyperactivity, vaginal bleeding, sudden change in fetal head position or station, pain in the scar, and maternal hemodynamic compromise. A sudden loss of station in a TOLAC is not a strange labor curve. It is a surgical diagnosis until proven otherwise. Now move to macrosomia. Macrosomia is a modifier because it changes mechanical probability, shoulder dystocia risk, PPH readiness, operative vaginal delivery risk, and counseling. But it is also dangerous because the modifier itself is uncertain. Estimated fetal weight is not birth weight. The local macrosomia protocol defines macrosomia as birth weight over 4,000 grams, regardless of gestational age. It immediately warns that ultrasound, clinical estimation, and the multiparous woman's report have similar and poor accuracy, especially above 4,000 grams, and that ultrasound often overestimates in that range. This means suspected macrosomia is not a precise diagnosis. It is a probability signal. That probability still matters. The Israeli position paper says macrosomia increases maternal risk of cesarean, postpartum hemorrhage, and perineal tears, and increases neonatal injury related to shoulder dystocia. Local protocol notes complications are more frequent above 4,500 grams. It also notes something every resident should know. Shoulder dystocia is more common in diabetic women, but most cases occur below 4,000 grams. That one sentence prevents 2 errors. Do not ignore shoulder dystocia below 4,000 grams, and do not treat every estimated 4-kilogram fetus as if shoulder dystocia is inevitable. Thresholds differ by source, and this disagreement is educational, not clutter. The Israeli position paper recommends cesarean when estimated fetal weight exceeds 4,500 grams without diabetes or 4,250 grams with diabetes. The local protocol recommends cesarean above 4,500 grams without diabetes and above 4,000 grams with diabetes. The same local note records that ACOG uses higher thresholds, 5,000 grams without diabetes and 4,500 grams with diabetes. RCOG is quoted locally as recommending cesarean over 4,500 grams in diabetes without an unequivocal recommendation for non-diabetic women. What should the resident learn? Not a single global number detached from context. Learn that diabetes lowers the threshold because fetal body composition and shoulder dystocia risk differ. Learn that local practice may be more conservative than ACOG. Learn that uncertainty in EFW must be part of counseling. And learn that suspected macrosomia is not, by itself, a diagnosis of CPD or contraindication to labor. The local protocol explicitly says suspected macrosomia is not a contraindication to instrumental delivery, but shoulder dystocia risk increases in instrumental deliveries. It also says suspected macrosomia is not a contraindication to TOLAC, although VBAC success decreases and rupture risk may be increased. Those sentences are exactly how modifiers should be taught, not as absolute prohibitions, but as changes in probability, preparation, and threshold for abandoning unsafe plans. Diabetes deepens the macrosomia story because the mechanism is not only weight. Maternal hyperglycemia drives fetal hyperinsulinemia.
Insulin is a fetal growth hormone. Diabetic fetuses can have disproportionate shoulder and trunk growth, which is why the same estimated weight may not carry the same shoulder dystocia risk in diabetic and non-diabetic pregnancies. Diabetes also changes intrapartum management through glucose control, neonatal hypoglycemia risk, and greater need for coordinated maternal and neonatal planning. Now, rupture of membranes. PROM and PPROM modify time because ruptured membranes turn waiting into infection exposure. Before rupture, a long induction is mainly a question of cervical biology, maternal exhaustion, uterine workload, and fetal status. After rupture, the clock also asks about ascending infection, GBS status, fever, chorioamnionitis, and the number of examinations. Gabb summarizes the trade-off well. At term or near term, early delivery after PROM can reduce perinatal infection without increasing operative delivery. Remote from term, careful conservative management may reduce gestational age morbidity, but infection risk remains central. PPROM is not one disease. It is rupture plus gestational age, plus infection status, plus fetal status, plus neonatal capability.
The practical resident behavior is to avoid unnecessary digital examinations. Digital exams after ruptured membranes can increase infection exposure, and in PPROM, they can shorten latency. Use sterile speculum examination and appropriate testing when diagnosis is needed. Do not repeatedly examine the cervix simply because everyone is curious. Local PPROM from 35 weeks illustrates how a protocol converts biology into action. If GBS is known positive, treat for GBS and proceed to immediate delivery. If GBS is known negative, do not administer antibiotics, and conservative treatment until 37 weeks is recommended. If GBS is unknown, obtain a swab and begin penicillin while awaiting the result. If positive, continue antibiotics and deliver. If negative, stop penicillin and continue conservative treatment to 37 weeks, according to protocol. Chorioamnionitis changes the conversation again. The local infection protocol states the main treatment is delivery plus antibiotics, and that diagnosis during labor is primarily clinical, relying on maternal fever with additional findings. Once infection is suspected, the question is not, can she meet the full failed induction clock? The question is how to deliver safely while treating maternal infection and protecting the neonate. Now, PET and hypertensive disease.
Hypertensive disease modifies labor failure reasoning because maternal disease may determine timing before labor criteria do. PET is not an arrest diagnosis. It is a maternal vascular disease with fetal consequences, placental dysfunction, growth restriction, abruption, fetal tracing abnormalities, prematurity, and maternal neurologic, hepatic, renal, hematologic, and pulmonary risk. Local timing rules are a useful framework. Chronic hypertension is generally not delivered before 37 weeks unless other indications develop. Gestational hypertension should be delivered no later than 37 weeks. PET without severe features, consider delivery starting at 36 weeks and no later than 37. PET with severe features, delivery starting at 34 weeks, with earlier delivery subject to clinical judgment. Magnesium sulfate is used for seizure prevention during labor and for 24 hours postpartum in PET with severe features. These numbers matter because they change the purpose of induction. A 37-week induction for gestational hypertension is not an elective patient's exercise. It is a maternal risk reduction intervention. But even here, route is not automatically cesarean. The question remains whether vaginal delivery is feasible within a maternal and fetal safety frame. Severe features, uncontrolled blood pressure, pulmonary edema, abruption, worsening labs, neurologic symptoms, or non-reassuring fetal status may narrow the tolerance for a long induction. Mild disease with stable mother and fetus may permit a careful induction.
PTE also changes medication choices after birth. The PPH protocol lists hypertension and preeclampsia as absolute contraindications to methergine. That is not a postpartum footnote. It matters when you decide whether a prolonged induction, operative delivery, macrosomic fetus, or second-stage cesarean is increasing hemorrhage risk in a patient whose uterotonic options are constrained. Now PPH risk. Postpartum hemorrhage is not only something that happens after the labor course, it is something the labor course helps create. Local protocol defines PPH as bleeding over 500 milliliters after vaginal birth or 1,000 milliliters after cesarean. Severe PPH is over 1,000 milliliters in the first 24 hours. It reminds us that pregnancy expands plasma volume by about 40% and red cell mass by about 25%, and that shock symptoms often appear only after substantial loss, around 10% or more of blood volume. It also notes that atony causes about 70% of early PPH. The risk factors overlap directly with this course: prolonged labor, chorioamnionitis, prolonged Pitocin use, macrosomia, preeclampsia, abruption, IUFD, fibroids, and prior PPH. So when a resident says, "Let us keep trying," or "Let us move to cesarean," the hemorrhage plan should already be forming. 2 IV lines, blood bank awareness, anesthesia communication, uterotonics, and quantitative blood loss are not merely responses after hemorrhage begins. In a high-risk labor, they are part of good route planning.
VTE risk modifies the route decision as well. Pregnancy is hypercoagulable. Risk peaks postpartum, especially in the first week. The local VTE protocol states cesarean approximately doubles VTE risk, around 1 in 1,000, though vaginal delivery also carries increased risk compared with the non-pregnant state. It also gives practical restart timing for prophylactic anticoagulation. Clexane or Fragmin 4 to 6 hours after vaginal delivery and 8 to 12 hours after cesarean, if bleeding risk permits. In a patient with hemorrhage, hematoma, coagulopathy, or suspected intra-abdominal bleeding, pneumatic compression is used. This means a route decision is not only vaginal or cesarean. It is also bleeding versus thrombosis, neuraxial timing, mobility, postpartum prophylaxis, and rescue resources. Finally, twins. Twins modify labor failure through presentation, monitoring, second twin logistics, and senior readiness. A twin labor is not simply 2 singleton labors occurring in sequence. The first twin's presentation, the second twin's presentation, fetal weights, gestational age, chorionicity context, availability of ultrasound, anesthesia, neonatal team, and operator skill all change the safety of labor and delivery. TOLAC is not absolutely contraindicated in twin pregnancy in the Israeli position paper, but that does not make twin TOLAC ordinary. It means the decision requires the SCAR logic and the twin delivery logic simultaneously. The teaching point across all these conditions is the same.
Do not turn modifiers into automatic cesarean indications. That is lazy. But do not ignore them because the general labor rule sounds clean. That is dangerous. Modifiers change 4 questions. First, how much time is safe? In failed induction, more time may prevent unnecessary cesarean. In PROM with rising fever, more time may feed infection. In PET with severe features, more time may increase maternal risk. In TOLAC second stage, more time may increase SCAR exposure. Second, how much uterine stimulation is safe? Oxytocin in an unscarred uterus is one risk. Oxytocin in TOLAC is another. Prostaglandins in a scarred uterus are not a casual extension of induction logic. Prolonged Pitocin in a macrosomic labor may also increase atony risk later. Third, what is the probability that vaginal birth is mechanically reasonable? Macrosomia, diabetes, OP position, asynclitism, mid-pelvic station, and no prior vaginal birth all change that probability. They do not prove failure, but they should make the clinician more precise. Fourth, what will the chosen route cost? Cesarean may solve fetal or labor urgency, but it increases hemorrhage, infection,
VTE, adhesions, and future placental risk. Operative vaginal delivery may avoid second-stage cesarean morbidity, but it requires prerequisites and carries neonatal and maternal trauma risk. Continued labor may preserve vaginal birth, but it may accumulate infection, exhaustion, atony, fetal hypoxia, or scar risk. The final synthesis is this.
The best resident does not memorize labor failure thresholds as if every patient is the same. The best resident asks, what is the rule and what modifies the safety of applying it here? Scar modifies rupture risk. Size modifies mechanics. Diabetes modifies size distribution and neonatal metabolism. Rupture modifies infection time. PET modifies maternal timing. Chorioamnionitis turns delivery into treatment. PPH risk modifies preparation. VTE modifies route and postpartum prophylaxis. Anesthesia modifies what rescue options are available and how quickly. So when you present a labor failure patient with a modifier, do not hide the modifier at the end. Put it into the decision sentence. Say, this is a first TOLAC with no prior vaginal birth, on low-dose Pitocin with reassuring tracing, now at 6 centimeters after rupture. Say, this is suspected macrosomia with diabetes, uncertain EFW, slow descent, and rising concern for shoulder dystocia. Say, this is PROM with unknown GBS, no fever, and conservative management still appropriate under protocol. Say, this is PET with severe features. The induction clock is subordinate to maternal safety. That is how the course comes together. The thresholds give you structure. The modifiers give you judgment. Medicine lives in the space between them.